We present a case of duodenovariceal bleeding treated by Doppler-guided endoscopic cyanoacrylate injection. Duodenovarix is the most common ectopic varix. The etiology is portal hypertension. The most common site is duodenal bulb, or the second portion of the duodenum. Duodenovarix is difficult to visualize due to its location in small bowel and its proximity to the serosal layer. Duodenovaricial bleeding has high mortality. Currently, there is no consensus for optimal management. This is a case of a 72-year-old male with portal hypertension from portal vein thrombosis associated with adenocarcinoma in the head of pancreas. He was admitted for recurrent hematochezia and one episode of hematemesis. Prior extensive workup in outside hospital did not reveal a clear bleeding source. During this admission, we performed an upper endoscopy, which showed bulging in the duodenal bulb. This was thought to be due to extrinsic compression from pancreatic head cancer. Review of contrast-enhanced CT raised suspicion that the prior cavernous transformation of the portal vein has likely developed into varices next to the duodenum. Endoscopic ultrasound showed large blebs with blue hue in duodenal bulb with positive Doppler signal, which are most consistent with engorged collaterals or duodenal varices. During this admission, extensive workup for bleeding, which includes CT angiography, mesenteric angiography, EUS, capsule endoscopy, and tagged red blood cell scan, revealed that duodenal varices as the only possible source of bleeding. Upper endoscopy with through-the-scope Doppler probe examination was performed using non-EUS freehand technique. Red whale sign was seen on both duodenal varices. On Doppler examination, a continuous, strong, low-pitched hum was heard from both varices, indicating active venous blood flow. Each varix was successfully injected with 2 mL of undiluted N-butyl 2 cyanoacrylate as perpendicular as possible. The use of undiluted cyanoacrylate preserves the speed of polymerization when it comes in contact with blood and causes rapid thrombosis of the varix. There was a small amount of immediate back bleeding from both injection sites that quickly ceased. Post-intervention, repeat Doppler exam showed absent signal, indicating adequate immediate hemostasis. No further GI bleeding or immediate complications were noted during the hospitalization. Follow-up endoscopy 10 days later showed a small glue extrusion ulcer without Doppler signal. No further glue was injected. No recurrence of bleeding was noted at 3-month follow-up. Management falls into 3 categories: endoscopic management, interventional radiology procedures including TIPS, BRTL, or percutaneous embolization. Surgery is salvage therapy. Endoscopic management includes band ligation, injection therapies using sclerosant or tissue adhesive, and combination treatment. Endoscopic management is effective for hemostasis and can be used as first-line therapy. They are also less invasive than IR or surgery. However, it can be difficult to identify the extent of the varix and maintain full endoscopic visualization of the lesion due to the duodenal anatomy. Also, there is an increased risk for perforation using the method due to the relative thickness of the duodenal wall. Endoscopic band ligation is effective for immediate hemostasis in active bleeding. This technique could be easier than injection therapy. However, band ligation is limited if the varix is more than 1.5 cm. If the band does not completely ligate large varix, it may create a wide defect in the variceal wall after sloughing off of the band, which could aggravate the bleeding. Most importantly, it's difficult to achieve complete long-term eradication with band ligation alone. This is because band ligation has insufficient effect on the feeding collateral vessels, and duodenal varix is typically located in the serosal layer. For injection therapy, a sclerosant or tissue adhesive is directly injected into the varix to promote thrombus formation. It's effective to achieve immediate hemostasis, and also it's more durable compared to band ligation. However, expertise is not readily available in all centers in the US. Complications include tissue damage, which is little higher in sclerosant than glue, mucosal ulceration, perforation, and a small risk of systemic embolization. Cyanoacrylate is the most commonly used glue agent, but not all cyanoacrylate glues are the same. The risk of systemic embolization is theoretically lower with faster glue polymerization. Polymerization rate is affected by factors including specific isomer, additives, injection technique, and low platelet count. Polymerization is faster with 4-carbon alkyl group, which is N-butyl 2-cyanoacrylate. Importantly, cyanoacrylate is not FDA approved in the US for variceal injection, but it's widely used in the rest of the world for treatment of gastric variceal bleeding. In conclusion, duodenal varix is a rare condition that can be challenging to diagnose. Duodenal variceal bleeding has a potential for massive bleeding, high risk of rebleeding, and mortality. Doppler-guided cyanoacrylate glue injection is an endoscopic method to achieve immediate and durable hemostasis with potentially less tissue injury.